there. So I'm just going to throw out to our panelists a couple different cases, and I have a few questions, but for anybody who's still on the call, feel free to jump in and ask questions. I purposely kind of left these cases a little bit vague in order to allow for discussion, potential changes. So in the first case, we have a 50-year-old male. He's got a metastatic right colon cancer on presentation. He's obese, diabetic without neuropathy with fatty liver, has a non-obstructing 8-centimeter cecal adenocarcinoma that's been biopsy proven, and has these 3 liver lesions listed below, and that I won't read off. And so let me see, I'm just going to put Dr. Solomon on the spot, at least initially. Thoughts about, let's say, thoughts about chemotherapy versus upfront resection.
Sorry, my mic on, and I don't know if you can hear me.
See, I can't actually see the list now for some reason. There we go.
So these are left and right lobe of the liver. So
I don't know if Dr. Solomon dropped off. Dr. Kim's reading over here. Any thoughts on starting off with chemotherapy versus resection first?
Yeah, we can hear
Anybody
Dr. Solomon.
thinking
Dr.
about
Solomon
resection
was
first?
speaking.
Yeah, he was talking.
Oh, I can't hear. Oh, never mind. Sorry.
struggling to get my
Talking
mic on there. Sorry about that.
Oh no, it's, you know,
Can you
it's
hear me
me. I'm echoing. I'm turned off my speaker because Dr. Kim and I are echoing. Go ahead.
Okay. Yes, we have a right-sided colon cancer with 3 liver metastasis. Yeah, so left versus right playing a role here. You know, bevacizumab would be an option for this patient, 50-year-old with some comorbidities. Folfoxiri probably is not a great option. No neuropathy, so probably a doublet with Folfox would be reasonable starting approach for this patient.
And maybe Dr. Solomon, Dr. Kim, you guys want to weigh in on the number of cycles here? And I'll just throw out to maybe Dr. Martin. I have my own opinions about synchronous surgery versus doing this in a staged fashion.
In terms of number of cycles, the trials seem to all be designed around doing minimal number prior to curative intent surgery. So reassessing every 6 to 8 weeks with imaging and reassessing for resectability.
Yeah, and I would second that. Definitely the trend that I'm seeing is anywhere between 4 to 6 cycles.
Any concerns?
And I forgot on this case, if I remember correctly, the left lateral lesion and the segment 4A lesions, those were superficial, whereas I think you changed this one up a little bit. The segment 5-8 lesion was actually deeper, but smaller in reality. Is that correct?
Yes, I've been caught out. Maybe you want to comment a little bit on especially like the 0.6 centimeter lesion in terms of timing, and you didn't touch on this in your presentation. But
right.
Asked about the potential disappearance of the lesion and how you treat that. In the left lateral position might be relatively easy to deal with, but if it was in another area, let's say the segment 4A, would you be concerned?
Right, you can potentially put in a fiducial. It's interesting. I think there was a study out there. It was a survey, and it was essentially less than half of hepatobiliary surgeons put fiducials in. And I think in this particular case, typically if it's superficial enough, you can still appreciate a dimple at that area, even if it does disappear radiographically.
This is where I dive back into the view after taking the dog back outside, for those of you all else who are working from home. I'll just say we didn't quite tackle the synchronous surgery question, but I think, you know, for this patient, my bias as a colorectal surgeon, I tend to think be less concerned about the right-sided colectomies, whereas I tend to find that I would say that for most combined surgery involving the left side or particularly down in the rectum or sigmoid, tend to be more cautious and favor staged approaches.
And I think also it depends on the extent of the liver resection, as stated by Dr. Martin. If it's a fairly large, if it's a major hepatectomy or more, then I'm even if it is a right-sided cancer, I tend to be a little bit more conservative and would want to do staged approach, preferentially liver first.
Great.
Yeah, I tend to agree with you on being a bit more aggressive with the right-sided lesions. I mean, I think the leak rate is significantly lower, and patients seem to tolerate the surgery better. You know, unless you have specific patient factors, numerous risk factors for an anastomotic leak, I think in general, I think doing a right-sided resection synchronously is a reasonable thing to consider, at least.
And I'll just add, I think Dr. Raphael and I have passed, I don't think he's on the call, have also, at least he found that mobilizing the right colon out of the way helped him mobilize the liver down for some of the more difficult to reach lesions in the past. Our patients have done well with that approach.
I forgot, I meant to mention during my talk. So Dr. Solomon, do you know, so I had read, so bevacizumab is actually, we don't know the mechanism, but actually is hepatoprotective for the sinusoidal injury. And I don't know if you had heard or seen of that, but
No,
I came across it a couple times.
I've never encountered that before. I wasn't aware of that. Yeah.
Yeah. So now that I know that, I'm all for bevacizumab.
Yeah.
Great. I'm going to jump to the next case. If anybody else wants, I don't see any other comments here. Second case, 67-year-old. This is a man with recurrent metastatic colon cancer. So he had a previous lap sigmoid colectomy in 2018 with the pathology shown a PT3N2 microsatellite stable. He completed 10 of 12 planned cycles of Kpox, adjuvant Kpox, but had to stop due to neuropathy. And then about a year and a half later, after on surveillance, he had recurrence both at his rectosigmoid anastomosis and in the liver with both biopsy proven. And in this particular case, this was a patient who had a fairly large 8-centimeter segment 5-6 lesion abutting the right posterior and right anterior branches of the portal vein, a 1.9 centimeter segment 4 and a 1.3 centimeter segment 2. Dr. Solomon, let me kind of put you on the spot again in terms of thoughts about chemotherapy and regimens here for someone with neuropathy.
Yeah, it's a difficult case. I think the baseline neuropathy will probably be quite limiting. 5-fluorouracil and those trials to demonstrate a PFS benefit, so that could be considered alone without oxaliplatin. But with a metachronous recurrence, it may be just reasonable not to treat with chemotherapy given the limited benefits in our data, if resectable.
Right, and I think just for the purposes of this case, yeah, we would consider this one resectable. Dr. Kim, do you want to comment a little bit about your approach on this in terms of resecting this tumor and what is required, and maybe maybe you can work with, I think there's a little bit of discussion here that maybe Doctors Chisman and Tao can weigh in on about thinking about the role of Y90 or SBRT, particularly for an 8-centimeter lesion.
Right. So, of course, this is very difficult and challenging because we don't actually have the images. Should I just imagine the case?
Sure.
Right. So it is resectable with the right hepatectomy based on the abutment of the right posterior and right anterior branches and whatnot. This case was interesting because the lesions in segment 2 and 4 popped up while awaiting what were you doing?
Waiting surgery, but yeah, I guess let me get, without going too much into the details of the case, let me just kind of briefly say that we treated the patient with Y90, but I was privy to kind of an interesting discussion between the three of you guys about Y90, and even we haven't really talked about SBRT in the context of resectable disease, but it has come up, and so maybe you and Dr. Tao and Dr. Huntsman can talk about that a little bit and weighing these.
I think
factors.
you know, when I think about it, for I guess we tend to think about SBRT for unresectable disease a lot of times, and so I guess a lot of times the goal of I think SBRT isn't really to convert the patient to then become resectable. I think about it as kind of the definitive therapy, and hopefully the patient won't need surgery. So, but I totally understand, a lot of the surgical concerns in terms of, the fibrosis, and so what do we do if the SBRT doesn't work, and that lesion continues to progress, but like the studies I showed, hopefully, that would be in a minority of patients, anywhere from, the local control rates of a lesion treated is anywhere from, 75 to like upper in the 95%. So, the goal is that SBRT would be done, and that's it, that we wouldn't actually, try to, go ahead and do surgery when there are a lot of, potential, risk factors. I think the patient we talked about had a fatty liver disease, was obese, they have to undergo significant workup to see if they can even, be, a surgical candidate. So, it's definitely more complicated, if the SBRT doesn't work, there are no other sites of disease, but that's a lot of ifs, that the tumor biology really works out, that everywhere else is truly, controlled, and the single SBRT lesion that we treated actually is the only one that's progressing. I would say that would be, pretty rare of a scenario, but of course, it certainly can happen, and then that makes, surgery potentially a lot more challenging with fibrosis. But and some of it is anecdotal, like I know there are patients who have been referred to centers with a lot of experiences of doing liver surgery after radiation, and have had been okay with that, just developing experience.
And I just want to echo what you just said, Dr. Tao, in terms of usually, yes, I agree. I think of SBRT as when the patient's not a surgical candidate, or, when surgery is essentially less likely. And yeah, my concern is always, or the way it's been described to me, is essentially the liver becomes like a brick. And so it's incredibly difficult to actually cut through the parenchyma if you have to go back surgically after SBRT. And I remember specifically in the NCCN guidelines under principles of surgery, it's like really you reserve, so SBRT should really only be used in the context of a clinical trial, and not just, willy-nilly.
Yeah, but I think, that's kind of evolving and changing too, with the overall survival benefit of the SABRE COMET data. And, and a lot of it depends on the actual individual case. If the area that we're treating is very small, the fibrosis will be limited to that small area. So if needed, that hopefully could be resected. But again, kind of other cases, if it's just completely, invading into the vasculature and we have to treat that, then that becomes so much more difficult potentially if it needs to come out.